Our next speaker is Dr. Menaka Pai. She's a hematologist in McMaster for the last 12 years. She's also head of the benign hematology service at McMaster. Her research interests include VTE research methods in rare disease, clinical practice guideline development, and she's going to talk to us today about a thrombophilia testing algorithm. Menaka, welcome.
Thank you so much, Dr. Hebert. I'm just going to request remote control. It's such a pleasure to be speaking to you all virtually about Thrombosis Canada's newest online tool, which is our thrombophilia testing algorithm. Let me tell you all about my disclosures. I have very few of them. Oh, thank you, Holly. So I received a grant directed towards my institution from ISTH. I received an honorarium from Novartis. I've attended a one-day advisory board, which was sponsored by Pfizer as well. And, all right, thanks so much, Holly. I appreciate it.
No problem.
So listen, we're going to cover 3 objectives in the next half hour. You're also going to be hearing my 2 children go through the bedtime process. So hopefully they will be the only people screaming and crying during this presentation. There's 3 things we're going to really focus on today. We're going to develop awareness of inherited and acquired factors that promote thrombosis. We're going to understand the limitations and pitfalls of thrombophilia testing, and we're going to learn how to incorporate Thrombosis Canada's Thrombophilia app, which is our newest tool, into our assessments of patients with blood clots. So by the end of our time together, my goal is to make you feel confident about when and how to test for thrombophilia and how to really do it in a meaningful way. Next slide, please, Holly. Thank you. And you can just flip through all of those graphics. We're going to center our discussions on 3 real cases today. These are patients I've cared for over my 12 years in practice. The first is an older gentleman with a right leg DVT and a previous PE. The second is a young woman with an unprovoked PE. She's actually a firefighter. And the final one is an older woman, a university professor with a new portal vein thrombosis. Next slide, please. And you can just go through those animations as well, Holly. So before we dive into our cases, I really want to take a step back and offer some framing and talk about thrombophilia. So the real paradox of thrombophilia is that we tend to talk about them more than we actually find them. The vast majority of venous thrombosis that you're going to encounter are not due to insidious underlying thrombophilia. They can actually be explained by far more common risk factors, things like serious medical illness, surgery, immobility, or cancer. So if you hunt for thrombophilia in these cases, your hunt is probably not going to be fruitful. It will not be a good use of healthcare resources, nor will it really change the way we manage our patients. Now, there are some important clues that should make you suspicious about thrombophilia, and they should trigger you to think about zebras and not horses. But please take my word for it, these zebras are rarely encountered. Next slide, please. Thank you. So, and you can flip through to those animations. Thank you. Intuitively, when we see unusual or sometimes life-threatening clots, I think we feel compelled to ask ourselves why. We really want to look for an underlying driver. And I get that. In fact, I feel that compulsion all the time. And there are definitely a few thrombophilic states that do merit workup. But the practice that I see far too often, which is ordering factor V Leiden, prothrombin gene mutation, protein C, protein S, AT3 on a patient, that is simply not merited. So this kind of laundry list, inherited thrombophilia testing, is usually a bad idea. What I want you to understand is that this particular laundry list of labs is actually not very comprehensive. These assays, which I've listed to the right of your screen under inherited thrombophilia, they represent only the tip of the iceberg in terms of our knowledge of blood clotting. So if a patient has a very concerning clot, a negative lab workup should not make you stop their anticoagulation. There are also very few thrombophilic states that truly change management, and they're often ordered in anticoagulated patients or patients with an acute clot, and that can impact the accuracy of the test. And finally, Doing these tests can cause quite a bit of unnecessary anxiety in patients, and it can cause overtreatment. So if you're going to test, you have to provide appropriate pre and post-test counseling. This is crucial, but it's also very difficult. So I want you to have a healthy disrespect for that list of inherited thrombophilic states, but I do want you to have a healthy appreciation for the acquired thrombophilia. Now we're going to touch on these four entities throughout this talk, as they can be very important drivers of recurrent or unusual thromboses. And if you find them, that actually changes management. Now, confirmatory assays for these conditions, like the myeloproliferative neoplasms, PNH, antiphospholipid antibody syndrome, HIT, these can be really difficult to access outside of a large hospital lab. And I know that not all of you work in that setting, but that's okay. If you suspect one of these acquired states, or even something from the laundry list, I would suggest you consult a thrombosis specialist, you access Thrombosis Canada's Thrombophilia tool, which will guide you, or draw some cheap, simple surrogate testing that can give you clues to their existence. So let's quickly review these acquired thrombophilias before we get to our cases. Next slide, please. Thank you, Holly. So the first acquired thrombophilia I want you to know are myeloproliferative neoplasms. These are a type of hematologic cancer. Now, they're an important acquired thrombophilia to identify, because when we find them, it actually changes our management. We don't just anticoagulate, we also give cytoreductive therapy. It's a group of 3 clonal diseases: polycythemia vera, essential thrombocytosis, and primary myelofibrosis. And they're associated with some genetic mutations that are in the red box to the right of your screen. Now, MPNs are important because 1/3 of patients with MPNs will actually suffer a vascular event, either arterial or venous. So when you have a new clot and you do a CBC, and that CBC indicates elevations in the hematocrit, the platelet count or the white count, if the blood film looks a little unusual, or if you're dealing with a VTE in a weird site, you should consider MPNs. Now, it is important ultimately to confirm one of these genetic mutations, and that's where referral to a hematologist can really be helpful. But as a first step, a CBC, an LDH, and a ferritin is a good place to start. Next slide, please. The next acquired thrombophilia to know is paroxysmal nocturnal hemoglobinuria. Now, this is a clonal disorder of hematopoietic stem cells. These cells harbor mutations in a gene called PIG-A. So the cell is deficient in something called a GPI-anchored protein. GPI-anchored proteins do a lot of things, but one of the things they do is they're involved in blood clotting. They also protect red blood cells from getting destroyed in the body. So up to 10% of PNH patients present with thrombosis, and they tend to have multiple clots in both veins and arterial territories, and they have clues on their CBC. So again, if you do a CBC, you're going to find low counts because of that hemolysis. You might also find a high LDH and a high reticulocyte count. Now, you're probably not in the habit of doing the definitive test for PNH. That's peripheral blood flow cytometry with FLAIR. That's okay, because the prevalence of PNH is pretty low. It's between 0.5 to 1.5 per million. It's quite rare. But again, start with the simple test. And why do we care about PNH? Well, it's because when we find a clot, we don't just treat with anticoagulation. We also use the monoclonal antibody eculizumab, and that actually reduces the risk of thrombosis by 82%. So it does change management. Next slide, please. Our next acquired thrombophilia, antiphospholipid antibody syndrome. The tip-off here is unusual site clots, recalcitrant clots. This is an autoimmune disorder where antibodies attack platelets in vivo, and when they do that, they activate them and they actually prompt them to clot. Now, antiphospholipid antibody syndrome, or APLA, is a kind of tricky entity to test for. It involves assays of coagulation function as well as assays that directly look for the antibodies. Now, when you have coagulation function testing, it has to be done while off anticoagulation. And if you find an abnormal test result with any of the assays, you have to prove that it's persisting after at least 12 weeks. But again, if you see any of these red flags, it's important to reach out for help because you might be dealing with a patient with antiphospholipid antibodies. And again, finding it matters because the treatment of antiphospholipid antibody syndrome, it differs from run-of-the-mill clots, and the treatment duration is often indefinite. Next slide, please. Our final acquired thrombophilia, before we move on to our cases, is HIT, or heparin-induced thrombocytopenia. This is an alloimmune disorder. So when susceptible patients receive heparinoids, they form an antibody, not just to the heparin, but to the platelet factor 4 complex that it is stuck to. This antibody leads to platelet activation and clotting. It also leads to increased clearance of platelets by the spleen, so the patient ends up with a low platelet count. Now, there's a number of clinical clues to HIT. You may have heard of the 4T score, but again, I advise you to start simple. Just do a CBC in patients with blood clots, especially if they have a history of recent heparin exposure. The definitive test is a serotonin release assay, which is hard to get, but the CBC, which is the easy thing to get, is the way that you actually recognize that HIT could be a possibility. Next slide, please. And you can go through that animation. Thank you, Holly. So now that you're familiar with these 4 thrombophilias, I hope you understand why it's actually really important to move away just from that laundry list approach to thrombophilia and more towards a detective work approach. Now, some factors like recurrent clots, a young age, strong family history, they're going to lead you to consider inherited thrombophilias. Meanwhile, other things like lab abnormalities, comorbidities, they might lead you to think about those acquired thrombophilias. But either way, just like we do in all areas of medicine, remember to generate a pre-test probability, come up with some theories about what's going on before you draw any advanced blood work. Next slide, please. And as I mentioned, remember that anticoagulation can actually interfere with many thrombophilia tests. So the Thrombosis Canada app and the Thrombophilia tool will definitely guide you here. But if you're going to order testing, make sure that it's done correctly. Testing should not be done in individuals who've had a recent acute clot, shouldn't be done in patients who are acutely ill, and many tests require anticoagulant interruption if necessary. And that should only be done if it's actually safe for the patient. So with all those provisos in mind, let's get to the next slide. Let's get started on our cases. Let's work through them together. So if you have the Thrombosis Canada app on your mobile device, you can fire it up now and load up the tool. If you're on your desktop, maybe don't turn off my window, but maybe open up another browser window and navigate to the Thrombosis Canada site. Our thrombophilia testing algorithm is found under the Clinical Tools tab. Next slide, please. All right, our first patient. So this is an 81-year-old retired high school teacher who fell and sustained a hip fracture. Unfortunately, definitive repair of that fracture was delayed by a few days. He was in hospital and he did not receive VTE prophylaxis. Now, this man sailed through surgery, got prophylaxis afterwards, but then was diagnosed with a DVT 3 days post-op. When we met, he mentioned that he'd also developed a PE 6 years ago. He told me, this is not my first time at the rodeo. And at that time, he was hospitalized and bedbound with a bad bout of pneumonia. So what do we make of this new clot? You know, is it suspicious enough to raise red flags for an underlying thrombophilia? Now, certainly the fact that he had 2 clots is a little bit unusual. Next slide, please. When you fire up our thrombophilia testing tool, the first question you're going to encounter is whether this is the patient's first VTE. So because it's not, we can go ahead, we can click no, and go to the next slide. And it takes us immediately to a recommendation. So the Thrombophilia app has told us that patients should only be considered for thrombophilia testing, ideally with the oversight of a specialist if they are under 50 years old, if they have a strong family history, or if at least one of their clots was unprovoked. It also suggests that we consider thrombophilia if the patient has 2 or more provoked VTEs. So you can click to the animation. So what would a thrombosis doctor do? Well, I'll tell you what this thrombosis doctor would do. So as I would with any patient, I would finish at least 3 months of therapy before I even think about testing. I would then bring this gentleman in to discuss treatment options, his ongoing risks, how he even feels about being on blood thinners, and what his worries are about the risk of recurrence. Now, our retired teacher has had 2 provoked VTEs, but as Dr. Hebert mentioned in his talk, these provoking risk factors are pretty strong, and they're also pretty transient. So hospitalization with bed rest and acute illness, and an unrepaired hip fracture. So what's the risk of recurrent clot? Probably about 2 to 3%. And in my experience, most patients and providers would not opt to treat patients like this long term, and many would not opt for thrombophilia testing, because no matter what we find, it's probably not going to change management. So doing testing here, it's just really not meaningful. Next slide. Okay, our next case is a bit more complex. I remember this woman very well. She was a young woman who was a firefighter in the town I practice in. She came to our Emerge with a large and completely unprovoked PE. No pregnancy, no hormone use, no hospitalizations, no illnesses, healthy, brand new clot. Next slide. Now, if we go to the app, we're going to indicate that this is her first VTE, and it was a doozy. Next slide. We're then prompted about the location of the VTE. So we're going to indicate this was a usual site clot. So this is a garden variety lung clot. Next slide. Now, it appears to be completely unprovoked in discussions with the patient. Next slide. And the tool takes us to this recommendation. So it tells us to consider thrombophilia testing with specialist consultation if this clot occurs with a number of factors. So it asks about concomitant arterial disease. It asks about a young age, a strong family history, a CBC abnormality, or autoimmune disease. Now, please note the autoimmune disease mentioned. The app makes special mention of autoimmune disease because of the relationship to antiphospholipid syndrome. So in young women, especially those with recurrent pregnancy loss, autoimmune disease, or recurrent VTE despite adequate anticoagulation, you really should be thinking about this entity, but it does not apply to this patient. So you can click through, and what would a thrombosis doctor do? So this young woman had a big, scary clot, and the risk of having a recurrent VTE here is low. It's about 3% per patient year. But that risk could be amplified if the patient goes on to use hormones or if she becomes pregnant. She meets a lot of criteria for thrombophilia testing. You know, she's young, she's had a big clot. Now, I think it's unlikely that we would actually find a condition that would change management here. But if we do find a thrombophilia, or even if we don't, it might enhance the patient's understanding of her condition. And that's important. You know, for that reason, testing might actually be indicated. Now, if testing is offered, it should be accompanied by thorough counseling about what the implications of positive or negative results might be. Next slide, please. Okay, this is our final case. A very dynamic 65-year-old university professor. She comes to her family doctor with new abdominal pain, and she was found to have a portal vein thrombosis on ultrasound. This is something many of you might have encountered in the past. Portal vein thromboses are pretty rare, but they are an incidental finding that sometimes comes up. Now, this woman was on hormone replacement. Blood work done on admission showed an elevated platelet count, but not much else. Now, when I interviewed this patient, she mentioned some additional history findings that I thought were kind of interesting. So she told me that for the past 2 years, she'd had migraines with auras, not under any treatment. She also had really painful fingers. They were much more pronounced in the wintertime or when she was reaching into the deep freezer in her lab. But the symptoms of redness, burning, stabbing pain, they kind of lasted year round. And she had seen her family physician, a neurologist, a rheumatologist, a vascular surgeon. She'd even seen a naturopathic doctor. Nobody had been able to explain what was going on with her fingers. So next slide. We go to our tool. We confirm that this is the patient's first VTE. Next slide. Now, the site of this clot, it's not usual. This is definitely an unusual clot. And when we talk about unusual clots in Thrombosis Canada, we mean intracranial clots, so cerebral vein or sinus clots. We mean abdominal clots, or we mean clots that are in both of the arterial and venous circulation. So if you have clots in these locations, that should really raise flags that something weird might be going on. Next slide. Now, because this woman is on exogenous estrogen, I am going to call this a provoked clot. Next slide, please. But as our first speaker mentioned, hormones in pregnancy are actually a pretty weak provoking factor. Next slide, please. So the tool now takes us to the following recommendation, very similar to our last patient. It tells us to consider thrombophilia testing with specialist consultation for this type of clot if there is concomitant arterial disease, young age, strong family history, autoimmune disease, or CBC abnormalities. Now, this patient meets one important criteria for potential thrombophilia. She has an abnormal CBC. So remember that elevated platelet count. Thrombocytosis can be a sign of myeloproliferative neoplasms. If you encounter elevated platelets, hematocrit, or white count, if you encounter blood film abnormalities, or even pancytopenia, you need to consider MPNs. And the CBC abnormalities can also tip you off to other acquired thrombophilias. You can click through, Holly. Thank you. So what would this thrombosis doctor do? I'll tell you what I did. I'm also a hematologist, so I repeated the patient's CBC, confirmed that that high platelet count was legit. I also checked a ferritin. Many of you probably know that iron deficiency can be a good reason to have high platelets, but I could not explain her high platelets with iron deficiency. And on exam, this woman had clear-cut erythromelalgia. So she had attacks of painful red fingers. And this happens to be a hallmark of myeloproliferative neoplasms. She also described symptoms of transient ischemic attacks. So it turns out that those migraines with auras, which she had been treating by Googling her symptoms, were actually not migraines. They were TIAs. So she was having arterial circulation compromise. Now, I went on to do a bone marrow biopsy. I checked for culprit mutations. I was able to diagnose this woman with JAK2 positive ET, or essential thrombocytosis. Now, in our previous cases, I really tried to hammer home that we really shouldn't do thrombophilia testing if it's not going to change management. But in this case, that thrombophilia test was essential because the risk of recurrent thrombosis and ET is over 20%. There is also a risk of conversion to myelofibrosis or even to acute leukemia. So finding this thrombophilia was a game changer. So in this woman's case, I added aspirin, I started cytoreduction with hydroxyurea, and I ensured that she had follow-up with my other hat on as a hematologist. Next slide. Okay, so our last case is a bonus case. It illustrates how the Thrombosis Canada tool performs under kind of unusual conditions. So this is more of an inpatient case. This is a 65-year-old man who had a STEMI 6 days ago. He had a CABG 3 days ago. This was a high-risk heart attack he had. And he was just diagnosed with a new DVT, so our service was consulted. But interestingly, he developed thrombosis despite being on aspirin, clopidogrel, and IV heparin pre-op. And then they put him on aspirin and low molecular weight heparin post-op. So his CBC showed a hemoglobin of 95, a white count of 7, and a platelet count of 46. Now that's low. I can tell you that his platelets were 180 prior to all of this excitement that he went through. Now, apart from his new clot and the fact that his platelet count is a little low, he was actually doing really well. So if you use the app, you can see the check boxes here. This is a first site VTE. It's a very boring usual site DVT. It occurred in the context of surgery, which is a strong risk factor. So you might be tempted to turn down the dial on your thrombophilia radar. But wait, there was a strong provoking risk factor, surgery. But some of my colleagues would argue that given that this man was on really hefty VTE prophylaxis, you could almost think of this clot as unprovoked. He had a clot despite full dose anticoagulation and then very rigorous prophylaxis. You might also notice there is a CBC abnormality here. Now, it's not uncommon for platelets to drop following open heart surgery. So we know that these little cells get eaten up by the bypass machine. But at 3 days post-op, your platelet count should actually be rebounding. They should be on their way up. So this platelet count of 46, we cannot blame that on the bypass. So what is going on here? Well, our 65-year-old man had heparin exposure in the last 5 to 10 days, and his platelet count has dropped by over 50%. There's no other cause for his thrombocytopenia because he's feeling fine, and he has a new clot. This man has a ton of red flags for heparin-induced thrombocytopenia. And again, finding this thrombophilia does change management. So if we don't stop low molecular weight heparin and start an alternative anticoagulant, we're going to put this fellow at risk for further potentially deadly clots. So again, I want to reinforce the simple test, the CBC and history, which we can do in pretty much any hospital in Canada. That's what gave this away. I did have access to a serotonin release assay. This man's HIT assay was positive. He went on to receive treatment with fondaparinux. We transitioned him to rivaroxaban on discharge. But that sort of back to basics approach of looking at the CBC is what tipped us off to something being wrong. Next slide, please. All right, so, and you can flip through the animations here, Holly. This brings me to the end of my talk. So I hope after our time together that you appreciate the full scope of inherited and acquired thrombophilias. Empiric testing for these conditions, it's just not a good idea for lots of reasons, but most importantly, it usually doesn't change how we treat our patients. It usually doesn't inform their prognosis. Now, sometimes it does. It can impact how we counsel patients and how we manage them. And that's why we created the Thrombosis Canada Thrombophilia tool. So when you pair that with careful assessment of the patient and their general condition, that's going to help you decide if you should even embark on that search for thrombophilias. Thrombophilia testing is very fraught. There's lots of pitfalls. So a sound understanding of when, how, and why to test is so essential. Thrombosis Canada and its member clinicians are always here to help you navigate this in an evidence-based way. And my last slide, please. I'd like to thank a couple of people, the amazing team at Thrombosis Canada, Dr. James Duquettis and Dr. Chris Patriquin, who developed this tool with me, and my children. You have likely heard the one-year-old cry to this entire talk. He's usually happier, I promise. So I'm open to questions, Dr. Hebert.
Thanks, Menaka. You have a question up there. They're thanking you for the great algorithm. In ET case, how long do you anticoagulate? And if I understood correctly, you suggested to add ASA?
Yeah. So essential thrombocytosis is an interesting condition, as I said, really high risk of recurrent thrombosis. So there are open questions about how long we anticoagulate these patients, and there is some ongoing research being done out of McMaster in Ottawa. What I can tell you is this should kind of be considered a permanent risk factor for anticoagulation. That clonal disorder is not curable. It's never going away. So Jeff, to use sort of the paradigms you've talked about around duration of treatment, it falls down a little with ET. I tend to treat long-term. There's also some evidence about the addition of aspirin in these patients, not only to prevent anticoagulation, but we think it also can help those symptoms of erythromelalgia, the painful fingers. But any treatment of ET, I would suggest, leave it to us. Hematologists are going to be your value add here.
We have a great question up here, and I'm sorry I didn't look at this in my presentation, but in unprovoked VTE in a seemingly healthy patient, do you look for occult malignancy?
Oh, what a good question. And Jeff, when they say, do you look for occult malignancy, they're not talking about the hematologist. This is something that we're fully pushing back on our primary care colleagues. I'll tell you my thought. I'd love to hear yours. So, we have great research by Mark Carey's group out of Ottawa that actually asked this very question. Believe it or not, they did an RCT about this. And what they said was, if you have this kind of patient, you've done a good history and physical, you've done, the basic blood test, and the patient is not telling you any red flags, there is really no yield to searching for occult malignancies. And now what I say in my letters back to you folks who are, the real frontliners here, is I say, make sure that their age and sex specific cancer screening is up to date. And, I don't go on wild goose chases. I wonder what you're doing when you're getting these people.
I would agree with you. I mean, we've seen those from Mark, and you're really going on a wild goose chase with really no benefit in the end. But I agree with you. I think make sure that they've been tested up to date for colon, breast, prostate, etc. make sure, I mean, if it's a different story if they have a history of breast cancer or prostate cancer or whatever it may be, but in a seemingly healthy person like we got in this great question, I would agree with you. You don't go on the goose chase. So it's very similar to thrombophilia testing.
Yeah, absolutely.
That's great.
There's a few quick ones here I can see, Jeff. I'll whip through them. Rita, hi Rita, growing evidence around DOACs in thrombosis. I will say that more and more of our patients are preferring them like no evidence, right? But it's on us to generate that evidence for DOACs. In terms of mild positive antiphospholipid, listen, if you have a positive antiphospholipid and it's meeting your lab criteria, it's repeated 12 weeks later, I mean, to me, that is a real antiphospholipid antibody, and I treat it as such, which means extended duration anticoagulation. If it's triple positive, I will choose warfarin because we have evidence for that. And, you know, massive provoked PE would shock. I'm going to turn it over to the rest of you. You know, really that we would treat for 3 to 6 months, and then we talk about the pros and cons. And we would certainly consider thrombophilias if there's red flags, but you know, I don't extend duration just because something is massive, and I don't consider thrombophilias just because something is massive, Genevieve. But thank you for the question.
All right, thank you, Menaka. That was great. Thank you so much. All right,